Good morning, everyone. I hope you're all doing well today.
Good
Thank you for
morning.
joining us.
Hello.
Hello. Hi. Thank you for joining us today for our monthly Quality Leaders webinar. I'm Stephanie Brown with Constellation Health, and I am a nurse consultant. Joining me as co-host, I have Alyssa Fischel, who's our director of our QIO and PAC services. We have Peggy Peterson, who is a quality improvement specialist. And we have Olivia Smith, who is an administrative professional and all-knowing for technology. So any issues with technology, she's our girl. We are in good shape. So we're happy, again, that you joined us. We have an extremely special presentation today by Amanda Bulgarelli. And she is Teepa Snow's daughter, for those of you who don't know. And she's going to be speaking to us about the positive approach to dementia care. I'm sure you have all heard of her. I know everybody's been very excited and waiting for months for this presentation. So I would like to introduce you to Amanda Snow Bulgarelli. Amanda has a master's degree in educational leadership and administration. Amanda has worked in education for over 10 years before joining the Positive Approach to Care team as lead mentor, speaker, and COO. Growing up with Teepa Snow as a mother, Amanda has been part of the Positive Approach to Care from the beginning, serving originally as a teenage volunteer and techniques. Amanda's skills and experience working with students and adults from around the globe have proven to be a tremendous asset. Through her years of teaching, she has developed the ability to give each person in the room an individual experience while learning new information and skills. Recently, Teepa and Amanda co-founded the Snow Approach Foundation. It's a nonprofit organization based in Hillsborough, North Carolina. Everybody know where Hillsborough is? Well, no. The Snow Approach provides services and education for those living with brain change and for those who support them. Amanda enjoys helping to improve awareness about brain change with the goal of helping and developing a more inclusive global community. Amanda will take questions as we go. We'll kind of watch the chat. I'm not going to stop every minute, but we'll kind of go and be watching the chat. But other than that, I'm going to be, what's the word I'm looking for? Gratefully and proudly and all those great words, then I turn it over to Amanda.
Awesome. All right. Well, hi, everybody. It's a lot to live up to. Man, I don't know whose bio that is, but hopefully you feel like, yes, everybody in the room gets a chance to say something and ask something. I have started us off with someone who you may or may not recognize. So I have here, yes, she's my mom, and also she's in the building next door. And they're doing a certification course right now for about 30 people who are coming in from all over the world to do her techniques. And
Wait a minute. I need to ask something. Which of you is in charge here? Who's in charge of this rodeo?
Oh, Teepa, you're wondering who's in charge.
I want to know who's the one that's going to be doing something here.
Yeah, I think that's Stephanie. Stephanie's for sure in charge.
Stephanie, where are you? I need to talk to you.
I'm right here.
Listen, I'm here because my mother did not get taken to the bathroom this morning or yesterday morning. And I have a bone to pick with you. This is absolutely ridiculous. Do you know how much money I'm spending to have her here? Do you? Don't just nod your head at
Okay,
me
pause.
like a puppet.
Pause. How many of you have been in Stephanie's position before? And if you're off camera, you can give the little hand up. You can let us see. Yeah, Dana had to come on for that one. Yeah. So give us another.
Wait, I hate to bother you. I know you're a busy person, but I do not understand why you want to move my husband to memory care. He is not that bad yet. And I do not want him back there with the zombies. Please do not put him back there with those zombie people. He is not that bad. It was my fault. I should have not gone to Bridge. I should have stayed at the apartment. I went down, and please don't put him there. Please don't
Okay,
do this.
pause.
Oh, I want to help her so bad.
How many of you have been in that situation on the receiving end of please don't put them in this place? Please don't make that shift, or I can't bear to think about my person coming into your care. Oof.
It's me.
Uh-oh.
I want to
Yes.
know who can get some medication on board, because I am telling you right now, I am telling you, I am quitting if you guys do not figure this shit out. I have reached my limit. She pulled my hair and I am done. I am done. If you can't get something on board for her, I'm not working this unit again. I am not working back here. I don't know what you people out front think is going on back here, but I don't have enough staff and I am having to go in and do the basics and I can't get the paperwork done. You figure out how you're going to do this.
Wow. Okay, so pause. Who's been in that situation? This is not family. This is staff. This is people that you're trying to support and work with.
I have goosebumps right now. I'm reliving these things.
Which is why we've given Manda the job of working with you after I stir the pot. We know the reality. I mean, I've been around for 45 years, so I know the reality of the work that you try to do and how in many ways it feels almost impossible to do what you're being asked to do with who you're being asked to do it with in situations that you're being asked to do it in. And part of what we know is that what we currently are doing for our staff, our families, and ourselves is we are not necessarily as well prepared as we should be to do this work that we want to do, because all too often people think there's not that much to it. It's dementia. And preparation wise, professionals receive little that helps them in the day-to-day function, but families receive almost nothing. And they are walking into this blind. And by the time they're asking for your help, your assistance, your placement, your support, your services, they have already poisoned the well accidentally by not understanding and knowing anything else to do. And so often they come into this feeling fairly frustrated with life and wanting things to be different and thinking that they're bringing their person to a place of expertise so that you, my friends, will be able to fix what is wrong. And I can have my mom back, my husband back. I don't want to see this thing changing. I want this, and I'm paying money for this, or I'm supporting this in some way. And so y'all are being asked to do a lot. So we believe that by preparing people better, and it's not rocket science, but there is a science to it, we can make a huge difference in how well people are able to do their work and how satisfied they feel at the end of the day. So whether they'll want to come back tomorrow and how much time they're spending in your office or you're spending on the floor trying to resolve issues that we don't want to actually even have in the first place, but we do. And it actually is not just about staff. I'm gonna ask us to put our hand up and own that we have to help families because they haven't been helped before that. We are not getting people hooked in early enough to keep them from getting to this place of acute distress when they're in a situation where we've had to change housing situations. And we're asking them to change housing.
Yeah.
So I'm going to pause and Amanda's going to kick back into gear. I appreciate so much what you all do. I don't know how you do it some days. And I know that we're burning you out at an alarming rate and we can't afford that. We really can't, because you're the backbone and the brain. So we need your backbone, but we also need your brain involved. So thank you for what you do. And we're glad to be of service in any small way. So thank you.
Well, and please let us thank you. I mean, you're a pioneer in this. You are. I mean, I just hear the name before I knew who Teepa Snow was. It took me one time to realize this was somebody big. And so that you devoted your life, and now Amanda, you're doing it right behind her, is such a, I'm sure it's a work of love for you, and it's a passion, and it's a calling. And
Yeah, it's not okay. Yeah, it's really not okay. And it wouldn't be okay for anybody on this call to be identified as having dementia and be treated as less. So
Yes.
we need to make that shift.
So
So thank you all. Absolutely. My pleasure. All right, have fun.
All right.
She'll be less scary than me, maybe.
Fingers crossed. But
Fingers crossed.
no promises. All right. So welcome everybody. I'm glad you got to experience a little time with Tifa. She is actually here as Stephanie mentioned, in Hillsborough, North Carolina, a lot of the time, and we are doing lots of training and certifications. So if after today you are inspired and you want to reach out, this is the place where you will be able to get your slides, but also the place where you can connect with us, or just let Stephanie know and say, hey, I really want to get up with them to figure out what to do, and we'll be that main point of contact. Because our goal really is to radically transform the experience of dementia, and it can't keep going the way it's going. We've got to shift it for everybody, for you guys, for staff, for families, for the people living in these places and spaces that we try our best to run. So today is I wish I could be like, hey, in an hour webinar, I'm going to help you figure out the answers to all those 3 questions that she brought up and more. And I hate to say it, but it's not going to happen. But we will get a little taster, and hopefully you'll walk away from today with some new awareness, some new knowledge about dementia and dementia care, and then some skills. What do you do? Even just one thing you can do walking away from the webinar. That's my goal for today. And maybe that thing is that, hey, I want to get more information on this. I want to figure out how to help and support my team. So here we go. We mentioned Snow Approach Foundation. We work as a nonprofit in Hillsborough, but we serve globally. We'll be recording videos, we'll be recording trainings, and we offer our certification courses in-house at Snow Approach Foundation here in Hillsborough. And all of those are through TIPA's global company, Positive Approach to Care, just as kind of a, what the heck are these 2 different things that we do? This is our organizational chart. You can see a lot of people are under and behind and supporting TIPA and I. And so many of the folks that we have in our chart are people that you may or may not be connected with. And as organizations, we have Jamie, who runs our designated orgs program, where if you have certified individuals, then you can become part of our designated organization. So I wanted you to kind of just get the groundwork of all these other names, because it's not just Tipa and I. We have a big team supporting us, and even more mentors all over the world. Here are those certifications that I talked about in designated orgs, and we also offer a positive approach to leadership training. So there's a lot of ways to get connected. Today, we're going to focus a lot on this champion skills. This is the core of what TIPA has created over the years. It's your positive physical approach. How do I close the distance between this person and this person in a way that feels good and okay for both and causes the least distress, so that we can actually get some stuff done together? And so that's at the core of everything that we do. We start with those champion skills. So let's talk a little bit about skills and training, because this is at the core of the issue, I think. And this is an opinion piece, but it's based in fact and numbers and data that is accurate. So right now, I'm wondering if you guys can either put it in the chat or speak up out loud. That's either way is fine. How many folks do you think are getting an accurate early diagnosis to up through the middle of the journey? So we use GEM states to talk about the journey. Sapphire is no brain change related to a dementia, healthy, flexible brain. Diamond is early state, meaning anywhere from 0 to 10 years in, because sometimes symptoms don't show up until 5 to 15 years into the journey. And so diamond state is early, before it's definitely a dementia. The middle of the journey we call emerald state. It's when someone is having some flaws, some things are happening that really couldn't be anything else. And that's usually when we start the diagnosis process. So how many people out of 10, or you can give me a percentage, how many people do you think are getting an early to mid state diagnosis versus a mid to later state?
None.
None. Okay. It's slim to none. 2. Okay.
The large minority.
Large minority. You guys are on it. I mean, we know this is a glaring issue right now. In fact, only 2 out of 10 people, and that's high. Some states are lower, some states are higher, some counties are higher, right? Depending on who's on board in the medical community. But yeah, only 20% of people are getting an early up through mid-state, even talking about the diagnosis. And then what's the wait time when you say, hey, okay, we're ready to go in and do this thing? 6 months to 2 years. But that's just the first meeting with the neurologist. And then what about that diagnosis process? 2 to 5 years is on average what we're hearing. So who's coming to you guys? Mostly people who have diagnoses or something else?
More that haven't diagnosed.
More
I
that
would say
they haven't been diagnosed,
past the
but they're
mid.
needing some support in some way, shape, or form, right, Veronica? It's like they may not carry a diagnosis, and there's something going on that has been making it really challenging to live in my personal space on my own independently, which is why I'm seeking support. And if we have 7,000 people right now, this is in 2020, but so it's more, right? 7,000 people over 65 who are living with dementia, who are recognized as living with dementia, or 7 million. Ugh. What does that mean for the actual number? If this is only representing 20%, the number is just huge. And it's why we're not looking earlier. It's why we trained a lot of primary care physicians here in Hillsborough, and their response was, we don't even have anywhere to send people if we do diagnose it early, if we do start to notice signs. Because if I send them to neurology, they're going to get medicated, or they're going to have to wait 6 to 18 months before they can even get their first appointment. That's a long time for me to tell a patient, hey, there's really nothing I can do, and there's really nothing you can do, but there's probably something really wrong with your brain. Go and sit with that for a while. And they were really honest, like, this, it sucks. We don't know what to do. And so that's where we're working to rebuild and reshift how we're thinking about it. Getting early screenings, getting early diagnostics that don't require a full workup, like an animal fluency screen, is something that could happen on a 6 months or annual basis that would help us become more aware of what's changing for someone before we go through that diagnostic process, which is hours and hours and may not even really give us a great result. So we know some of these living options. We know we've got in-home support, either health or not. We've got respite programs. We've got day centers, either health focused or not. Senior communities, continuing care, independent living, assisted living, dementia-specific, often called memory care, as Teepa mentioned, the place that nobody wants to go. And I mean, this is people. This is not us saying it, right? How many times have you heard that sentiment? Well, I don't want to go down there. That's where people go to die. It's really a different hallway, but it's the whole world. It seems like it would change. When the reality is, who do you know is living in your assisted living? Who do you know is living in your independent living? Who do you know is living at home and getting support and really needs 24/7 but can't afford it? So the reality is there's a lot of people and there's not enough support. And you all are being asked to do a lot with very little. And even when you get someone in, okay, this is a number that just shook me to my core. So this is the certified nursing assistant requirements. To get your license as a CNA, there are a certain number of hours, clinical hours required across the US. There's like an average. What do you guys think that number is? This is for the whole training program. From start to finish, you have to have X number of clinical hours to graduate with a CNA license.
Are you talking just clinical hours? I mean, actually, after class, you have to go to a facility or a community to work?
Yeah, there's usually about 16 supervised hours afterwards, but before that.
I think I took at one point 35 hours.
A 35. Okay, so it's higher than that across the average now.
Oh, okay.
And it may include some didactic, which is video hours, right? Any other numbers people can think of? Higher than 35. I'll give you that hint.
Maybe
40
50
higher,
hours?
60 higher,
Higher than 60?
80 lower.
Come on, Chris is right.
75. Okay, so 75 across the US. Some states require more. Some states require 120 hours before you can have your CNA license. Okay, that seems like a lot, right? What do you think for a certified nail technician in comparison? And I mean like fingernails. I'm talking the ends of your fingers for the gels and the decoration and the careful cleaning and hygienic, and probably also your toes, right? Because I think they generally have to do both. What
Maybe
do you think?
1,600 hours?
How much?
1,600 hours?
1,600, less than that.
Okay, 1,000?
100 less than 1,000, more than
Okay.
160.
500,
Less than 500.
400.
Yep.
400?
300 to 400 hours is the average across the US, where 75 is for a CNA who cares for how much of the body?
All of the body.
All of the body. And how much is required if you work in a dementia-specific care, home, field, in-home care that says we provide dementia-specific support? How much additional training is required?
God, I don't have a clue. I was a caregiver at one point, but
Did they give you a lot of extra training when you went into dementia-specific fields
No.
or no?
no, not at
Oh.
all.
Right. So zero clinical hours required. If there is something required, it is video. Video is acceptable training to work in a memory care unit or a dementia-specific, our preferred term because more than memory, right? Dementia-specific care field. So how well are we equipping these people that we're asking to come in at $11 to $18 an hour and do the work that no one else in the room wants to do, and do the work that the families couldn't quite figure out how to do, and do the work that the person is not understanding because they have language changes? Why are we so fired up? Because this isn't fair. It's not fair to our staff, and it's not fair to our families, and it's not fair to our community, and things have to shift. We cannot keep accepting status quo because it's not working. We have the highest turnover rates. We have very low retention. We have low pay, low morale, low satisfaction, and yet people still show up. And we're telling them, listen, you'll figure it out. It's common sense. So what we believe is that people need more, and they don't need more education on a video. Yes, video is a really good starter, and it helps people become aware, and it builds some knowledge. I did something before I came on here today, and I'm willing to come to you if you're willing to let me. I watched 8 hours of video, which is the requirement, on how to put in an IV. And I just can't for the life of me find anyone who's willing to let me try on them, having just watched a video. And I don't understand why not. And I'm kidding, but I'm not.
Yes.
This is life or death care that we're asking people to go in and do after watching a video for 8 hours. We have to shift. We have to flip the script. We need live coaching and live support for people to feel like they know what to try, because it doesn't matter what I watched on that video. If someone comes down the hall, as Tifa did, excuse me, are you the one in charge? Because I'm not paying $16,000 a month to have you not take care of my mother. Guess who else needs training in role play and practical skills? Because how many of you don't know what to do in those situations? And then you just pass them to Stephanie, or you pass them up the chain, or you say, listen, I'm really sorry. I guess we're not the right place for you. And then they're out the door. And there goes your funding source as well. So these are big problems. And our goal is to help solve them through training and education. Because here's the reality. Our US care organizations, we have roughly, if you put all of these together, there are roughly 66,504. And if you remember that number from before, 7 million, and that's only the diagnosed folks, and then there's an 80% of people out there who are undiagnosed, needing support, that number is not enough to cover the level of care that is needed. And even still, these care organizations that we've got, how many of you feel like, yep, we are totally satisfied with our staff retention, with our morale, with our skills training, and with our numbers, the number of people in our building right now. And our waiting list is full, and we're a year out, and we feel really good about where we are right now versus something else. Yeah. And we get it. It's a crisis right now. And the solution takes time. It really does. And it takes training and education. So we have right now 34 organizations across the world who are PAC designated. They are certified individuals, at least 2 in their organization, a trainer and a coach, who are doing the in-person, in-service trainings after they've done the video. And then there's a coach who's on the floor or out in the homes, making sure that you're practicing those skills with support and feedback, and not feeling like you've got to just figure it out by yourself. And those organizations are the ones that have found some ways of success and have those full waiting lists and have those ways of supporting families as well as staff. Because our goal is to kind of move out of this thing that we call care, which is actually, if we don't provide the care and support without permission, if we don't know how to ask permission, then we end up doing something that's more like abuse, whether that's using 2, 3, or 4 people in the shower to help get clean, whether it's feeding someone and robbing them of their ability to feed themselves, whether it's arguing about any of the reality that's happening when what my reality is different than yours and making me feel less. Or on the flip side, it could be that when you refuse a shower, we just don't do it. Or you refuse oral care, we just don't do it. Because documentation matters. So either we're over medicating, over helping, over supporting and taking over, or we're letting it be. And neither of those situations, whether it's abuse or neglect, is really in the care field, but it feels like we don't have any other options. So that's what Tifa's been working on for 45 years. We've got options, and it takes time to learn those skills, and it takes a dedication and a buy-in at all levels. So here's some of the research that backs up this kind of training. If you're wondering, what do we do? How do we get this kind of training going? Well, clinical hours as a proportion of total, and clinical means, hands-on, you're in the field, you're out there practicing stuff. As clinical hours increase, there's a significant decrease at nursing homes of having residents with depression, regardless of the size. In addition, pain, antipsychotic, and weight loss were similarly related. So those went down as you up your clinical training. The number one request from all organizations we have worked with for the past 10 years since I've been here is we need more training and education. We just don't quite know how. Our how is bring it out onto the floor, make it smaller, 5-minute training, coaching in partnership or in threes on the floor. Don't take me out of my job. This is what I need on the job. Do it on the job. And we train people to do that as trainers and coaches. Another piece that's shifted, as you increase in-service hours, lower odds of fall with injury. And that's a key change there, because not lower odds of fall, people are going to fall, but less injury with the fall and lower odds of depression, regardless of the size. This is something that's really cool that kind of like backs up what we're talking about here. When you look at one of our organizations, it's our oldest and most skilled organization that's been part of this before I even joined Positive Approach to Care. It's called Hale Kawike, and it's led by Dorothy Colby, who's one of our mentors. She got trained in everything TIPA offered about 12 years ago, and then brought this into her organization. She got buy-in from David, her CEO, who is really hands-on and really wants to make this the best it can be. He says, I want to build the place that I would want to live in. And that's been their singular vision throughout. They had a doctoral student who came in and did a study. Does it make a difference if we train all of our staff? And he used the thing that a lot of medication companies use to measure agitation, the Cohen-Mansfield Agitation Inventory. So he did a pre and post, and the only thing that he shifted was that training was provided. And the training that they provided was a certified PAC trainer teaching our workshops to all of the staff. That was the goal, 100%. They got to 92.45% of staff participation, meaning everybody completed all 3 workshops, except for 8% of the folks. They gave the agitation assessment before and after that training. They also measured staff satisfaction. So with the agitation scale, there was a mean decrease in patient agitation at 6.07 points. And for staff satisfaction, using the Utrecht work engagement scale, there was an increase, meaning staff were more satisfied by 2.76 points. Now, it's hard to kind of put that into context. So, and this is not going to be in your slide deck, so I'll make sure that I share these 2 slides separately because I just added these in. But I wanted to put this into context of Rexulti, which is a more recent push to help decrease patient agitation, especially for folks living with dementia, but Alzheimer's, not the other dementias, because that could be deadly. But for Alzheimer's, we want to make sure that we decrease agitation. And so Rexulti has been the go-to. It's a off-label use of this antipsychotic drug. And so its praises have been sung, and there are lots of commercials. And so I wanted to just point out the difference in a non-pharmacological training-only approach to Rexulti. 6.07 points decrease in the agitation scale. Rexulti at best, compared to a placebo, is negative 3.2 on that same scale. So half the amount of decrease with a medication than with solely training. There was not coaching involved. That is just the training component. And they put this kind of small on there, but in clinical trials, elderly patients with dementia randomized to risperidone, aripiprazole, and olanzapine had a higher incidence of stroke and transient ischemic attack, including fatal stroke. Rexulti is not approved for the treatment of patients with dementia-related psychosis without agitation associated with dementia due to Alzheimer's disease. So tell me a little bit about, I'm going to stop share for just a moment. Tell me a little bit about how well people are getting diagnosed how accurate are their diagnoses? Would you be able to determine if they have this specific thing that they are allowed to prescribe for versus not?
No.
No. What's the typical diagnosis that someone comes in with? What do you see a lot of?
I remember seeing a lot of dementia with associated behaviors or dementia with behaviors.
Dementia being a very broad category and associated behaviors, whatever that means. Likely
Yeah,
agitation.
whatever that, yeah.
Okay. Unspecified dementia. Yep. Do you see a lot of Alzheimer's?
Yeah, I see a lot of wandering
Okay,
in
so
my
you-
unit. Yeah,
So some
wandering and
symptoms, but not necessarily like an actual diagnosis.
diagnosis. Yeah.
Yeah, with or without
With not.
agitation. What does that mean? So it's sort of an unrealistic conversation that we're being asked to try to navigate because we're not getting a clear diagnosis. And even if we are, it's only 20% of people early on up through the middle. And then, I mean, who's starting to feel a little bit overwhelmed by all of this stuff? Right? I mean, starting to maybe who's felt overwhelmed by this stuff for a long time. So when we start to think about, there we go. Okay. When we start to think about what do we do? Well, our vision is that we start doing some training and some education, and it starts with you. So thank you for being here. We do have a quiz on our website that is some of the questions from here and a bit more. If you want to put in have your team go ahead and take that quiz, we can get you the results to see how your team does. Because I think a lot of times we all think, well, we know dementia, and you do. You know a lot about it. And you don't have the specifics that are often missed in those training videos or in those hours because they kind of start at the challenging situations and they skip over all that basic brain content. So that's what we do. We do the brain content, we do what's changing for someone, and then we get you to those challenging situations. So here's our little office over in Snow Approach Foundation, and the building next to us is where you can come visit us if you want to have some in-person practice. And here's some pictures of our training. All right. So I'm going to ask you guys here, what are some words that you would use to describe this object without naming it? No nouns. You can't use any nouns, but what would you use to describe it?
Donut.
It looks like a donut, sure.
It's always going to be food for
That's
me.
a noun, just so you know, that's a noun.
Oh, I'm sorry.
That's all right.
It's always about food for me.
I know it. I hear you.
That's okay, Stephanie. How about circle?
Also a noun,
Yeah,
funny
oh
enough.
my gosh.
You guys are good at this game. Anybody have any non-nouns? You can use color words, you can use describing words.
It's gray.
It's
got a
gray.
hole
Oh,
in
good.
it.
Round and dark. Anna, good. You've got some good fifth grade language coaching there.
Maybe unwhole or
Unwhole. Okay,
yeah.
sure. And flat. Yes. How many of you are feeling like those are really super positive words? Not really. I mean, they're fine, but it's not like the most exciting thing, isn't it?
Right.
And so now I want you to imagine this is how we see, because it's true, this is kind of how we see someone living with dementia. There's some holes. It's pretty gray. It's pretty dark. It's tough. So us who are really like committed to making life different, we change something.
Is not available.
And what we generally change, here's the first change that we make. We change the environment. We put them in this beautiful environment. We make sure that they've got activities that we think they'll like and food that we know is really good, even though everybody complains about it all the time. And we make sure that they have a really nice room that looks like theirs and they've got their personal items there and blah, 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 blah. We change the environment. What's the problem still? How are we seeing the person?
We're not seeing them as a whole. They
We're
need to
seeing
go
them
in
as
and
unwhole. We're seeing
Mhm.
it as gray and dark, and there's something missing. And so Tiba's main focus in doing what she's done for 45 years is how do we shift this away from this image, away from this thought that this person is the thing that's making it hard, the thing that's unwhole, the thing that's there that we have to deal with. And instead, how do we shift that and take away the us versus them? Because any one of us are living with brain change, and any one of us could step over that imaginary line that one day says, I'm no longer capable to care for myself. And how many of you would be fine with that? You'd love to have everybody else do all the things for you. You'd love to let go of your independence. You don't want to have to drive anymore. It's great to have somebody drive you around anytime you need to go anywhere. It's great to have somebody bring you food in your bed every meal, every time, whether you wanted it or not. It's great for people to decide what you get to eat and what you like to do and which activities you have to go to. Yeah, no, because how we see ourselves is more like this. When I look in the mirror, I see all the great stuff. I've got sprinkles, I've got icing. I would be more like this donut. This is my kind of donut. But how many of you, this is not your kind of donut? You'd prefer chocolate. You don't like sprinkles. You don't want red. You want something else. And so this is how we choose to see individuals who are living with brain changes like dementia, as well as staff, as well as families, as well as you guys, the administration that's trying to make this work. And how much time do you think about the whole of a donut versus do you think about what's here? And in dementia, how much time do we spend looking at what's lost, what they can't, what doesn't happen anymore, versus looking at what remains? So our goal today and over the next X number of months that you choose to join us on this journey is to start to really notice, man, there's a donut. It's like, yeah, it's got a hole. We're not here to sugarcoat and make it seem like, oh, it doesn't matter. No, we want to validate those losses. We want to acknowledge and validate them. And then what else? What can I do with what's left? What can I see in this person who's still here? Because someone doesn't die over and over again when they're going through the journey of dementia. No, their skills change. And if we don't learn to adapt, then all we're looking at is that gray circle. Whereas if we can start to notice what they've still got in this journey along the way, man, they can still have purpose and value. And my job becomes to support that with the right setting and care. Because it's not just one donut. Y'all have a lot of donuts in your care. And where did that donut from before go? Is it here? And so you may not fit in the place that you're trying to be supportive in, and there might be others who also don't fit. So how do we build a more inclusive? How do we build more of a skilled and educated group? Well, here we go. Let's see what you know. Who in these pictures has dementia? Or had, I guess.
It's hard to tell. I mean,
Oh, why is it so hard to tell, do you think?
because there's all look so normal.
Oh, there's a lot of faces that don't show. It's what's called a hidden disability, right? So we can't tell from looking at someone. Often we don't really know unless we know them really well. How much do we actually get to know people before they get to move in with us? How often are families just so burnt out they can't do anything anymore? Versus, wow, tell me what your mom likes to do in her free time. Tell me what your mom will still be interested in. Anything that she actually really likes right now. Well, okay, well, tell me what she used to do. Those are questions that get really tough when everybody's at high alert, high energy, and high distress. So in this picture, yeah, we do know a few folks. We don't know everybody. And not everybody has dementia in this picture. In fact, Grandma Moses down here in the corner, famous artist, live to be over 100 and no dementia that we know of. So our goal is to prepare you. This is TIPA's PIPES model. So prepare, initiate. We often skip over the prepare step and we just have people initiate, get out there, do this, follow this person for a day, and you've got it. Get participation with or without permission, evaluate how it's going, and then decide, are you going to stay and be here tomorrow, or are you going to switch? And more often than not, people are switching because this is too hard because we didn't prepare. So we're not asking for a long time, but 5 minutes every day can help prepare your staff in a way that's a lot more effective. And what do you prepare them for? To notice and accept that we can change some things. Notice the place, is it working? Notice the people, is that working? Notice the props and the programming. And if none of those are things that would change the situation, if you can, or if you can't change any of those, what are some other possibilities? And if we can shift staff from thinking of, this isn't working, this is her fault, my fault, this is bad, to, I wonder what we could change, it'll be incredible for you to see them become part of the problem-solving team instead of feeling like they're part of the problem or the other people on the other side are part of the problem. So we take it from a blame statement to a curiosity. So let's go ahead and see what you guys know, because you guys are pretty smart. I've already figured that out. And there's a lot of misinformation out there. So what do you think is the first change for everybody that happens as we age? A, we lose the ability to learn new things. B, we all develop dementia sometime. C, everything slows down, intake, processing, and output. D, everybody gets hard of hearing. And E, I don't know. Okay,
I'm going to say C.
I heard a C. Good. C. Oh, wow. Yes. See, I knew it. I knew you guys were really smart. Yeah. So here's the thing about aging. We often say, oh, that must just be her getting older, but that's not accurate. Unless there's a change in speed, that is typical aging. Everything slows down. We have more words, so it takes longer to find the word. I have more faces that I recognize, so it takes me longer to recognize you when I see you out in public. It might take me a little bit longer to take my foot off the gas and put it on the brake, or take it off the brake and put it on the gas. Sure. And I don't lose function. So I don't start thinking differently. I don't make mistakes in my medication or my checkbook unless that's who I've always been and it's just now worsening. But typically, if I could do it before, aging doesn't take that skill away, it just slows down. All right. So here's two brains. These are brains that are alive. They're not being asked to do anything yet, but they're laying in a machine. 20-year-old brain. This is the red is like 100% burn of glucose. Yellow is like 75, green 50, light blue. There's tissue there, but it's not active. So this is a healthy 20-year-old brain, and this is a healthy 80-year-old brain. Notice if you can and share out anywhere you see drastic changes, or you can say, man, it all looks kind of similar to me. And we're really looking at the matchup and the color and the shape and the size.
On the 80-year-old, when I'm looking at it on the right-hand side, near the frontal lobe, yes, right around there is losing. It seems like it's lost some of its energy. Yeah. Okay,
so it's sort of like working harder, even just laying there in this piece here, and it's a little less active. There's a little less red over here in that sensory motor piece. Yeah, great notice. A little bit of frontal decline, not a huge amount, but there's a little bit here. There's a little less tissue. Somebody noticed, yeah, pretty good. Ooh, nice word, Christine. occipital lobe, this part in the back, it's in the back of your brain. We're looking at the brains like this. And this part in the back where there's vision, there's a significant change, not just in color, but also check out the structure here. So how many of you noticed as you've aged that your vision has changed?
Oh, gosh.
Yeah. For some reason, restaurants seem a lot darker after 40. I don't know why, but they just do. And cars like shrink or something, so you knock your head a lot, right? And you trip over a lot more sidewalks. Like the sidewalks get really uneven after like 30. Yeah.
Yes, they do. Yes.
They do. And it's because that's the one part of the brain that for everyone with typical aging, you will lose some processing space. Again, it's just processing. It's not actual function. But if you go ahead and take your hands and put them up like this, at age 75, this will be your visual field. Whereas at age 25, move it back here, this is your visual field. Without moving your head around, you can see all of that and process all of that vision. So with typical aging, you lose about a degree per year. So by 75, you've lost some of your peripheral field of vision. But that's just typical aging. That's the one big change. Everything else just slows down. All right, here's another question. What is dementia? I have a feeling you guys are going to know this one. A, problems with memory. B, another word for Alzheimer's. C, something everybody gets. D, another word for a failing brain. E, I don't know.
I'm going to say A.
A, okay. D. D, D. D, all right.
I switched. I'll take D.
Okay, good. I mean, it's really interesting that everybody in the chat is putting in D, and now that's making you think. Yeah, actually, it is another word for a failing brain. And here's what the crazy part is. We've been teaching this. I've been teaching this for 10 years, TIPA for 45 years. What do you think still 90% of people would put in these circles here if we're looking for a math symbol? Dementia is blank to Alzheimer's is blank to memory problems. %90 of people would put equals. And they have for 45 years because Alzheimer's is the one that's most talked about. And memory problems is the word that we use for a lot of things. And it's frustrating on our end because guess what? Not all dementias have memory problems associated. In fact, there are quite a few that don't, but Alzheimer's does. And not all dementias are Alzheimer's. And that's something that's really challenging for families. If you're thinking, well, they've got something going on, but the memory is fine. Guess what we won't do for a really long time? We won't explore dementia as a possible cause or a possible thing to even look at. And we're talking about 30, 40, and 50-year-olds who are going through these changes and the families don't have any idea what to do. So the best answer for us is that dementia, go ahead and think about dementia as an umbrella. Dementia is an umbrella term.
Okay.
Alzheimer's is a type of dementia, and memory problems is a symptom of Alzheimer's that is under the umbrella of a dementia. Yeah, oh, I have an umbrella slide. I thought it was next. I'll show you that, Stephanie, in just a minute. What do you see when there's a dementia with no memory loss? So for example, I had a husband and wife come in. He's 91. He's been coming into our day program a lot for 2 years, and we've seen him change significantly. He has vascular dementia. So vascular dementia, right, is that blood flowing to the brain, and there are things that are not flowing well. And so it can really stretch out a dementia, but it also, or your time, as long as all of your other health impairments are managed, if you manage that blood flow problem. And because it's a blood flow problem, if the blood flow to the memory section, the hippocampus in the brain, is good, you might never forget the person that you're partnered with. And so she said, well, I'll move him into a home when he doesn't remember me. And I said, ooh, I hate to be the bearer of bad news, but you're going to need a new threshold. Because if you wait for that, that may never happen with vascular dementia. And so we've got to have a better threshold. What's something else that would make it so that you can no longer do this in your home? Because him not remembering you cannot be the thing, because that may never happen with this type of dementia. So great question. All right, how long do people live when they get dementia? Not long, 1 to 3 years, 3 to 5 years, C, 6 months to 30 years, D, 10 to 15 years, E, I have no idea.
Ooh.
Okay, I got a
From
C.
beginning to end, like from the very beginning, but then we don't even know it yet, to
Sure, yeah, we typically say from diagnosis, but you can kind of stretch it if you'd like.
D.
C, C, B, D. Okay. Yeah, lots of different answers. So typically we hear D because, again, people associate dementia with Alzheimer's. Alzheimer's diagnosis is around the 10 to 15 year mark, with an average of around 12 years post-diagnosis. Again, diagnosis is not happening until later on in the journey. So if you found it earlier, that timeline would be a lot longer. Because of vascular and because of Creutzfeldt-Jacobs disease, which is like a mad cow disease, anywhere from, really, it should say 3 months to 30 years. There's a really, really big span. And that's what's so challenging, is if I, as the neurologist or the doctor, I give you your diagnosis and I say, go get your affairs in order, 30 years is a real long time to be getting my affairs in order and have nothing else to do. All right, what's the first change that happens with dementia? Brain shrinks, chemistry of the brain changes, or the person's personality changes. The person's behavior changes, or I don't know.
I'm going to say B.
You're going to say B, chemistry. E, I don't know. Good, honest answer. B, good. B, B. Oh, wow, very good. Chemistry can change anywhere from 5 to 15 years before we even start to see symptoms. The chemistry might have been changing for a long time in this person's brain, and it may never progress fully into a dementia. And it may progress into the dementia, and then we'll see symptoms for 5 to 15 years before we start to go through the diagnosis process. So this is it's a challenge. And a lot of it is genetic, and a lot of it is stress related, and a lot of it is depression related. And if we don't take care of those treatable conditions, we put ourselves at a much higher risk of developing our own dementia. So often when we see the care partner, who's the only, who doesn't have a lot of training, who's doing everything they can to help this person survive, and they are in high distress and getting very little dopamine and a lot of cortisol, and not finding relief and not finding respite and not finding a way to de-stress, the care partner is the one that often will develop their own form of dementia or cancer and end up dying before the person who's living with the condition. So this is a reality, and we want to shift that. All right, I think this is maybe the last two. We'll do them really quick because we're almost out of time. What parts of your brain will change if you get dementia? Memory and language centers die. B, thinking and behavior. C, all areas at the same time. D, all areas at different times. E, I don't know. D, wow, you guys are fast. I like it. I like the speed. Ding. Every part of my brain will change eventually, no matter which type of dementia. The type of dementia helps me figure out which part will change first. Which part will I notice symptoms? Which part will I start to see massive changes? And what comes later on? And eventually, if nothing else takes my life, my dementia will cause me to die. And it takes anywhere from 6 months to 30 years, depending on the type of dementia. So we got a lot of time before then to try to figure things out. We have this PET scan that you'll see here. Early Alzheimer's compared to typical aging over here. Notice there's a lot of vision change. There's a lot of amygdala action happening. And there's a lot of prefrontal happening that's making it more and more challenging for me to be in this world without feeling threatened. My amygdala is my threat perceiver. Here, those are those hippocampal areas. Those are for memory. And already the structure with Alzheimer's has changed. So we're going to do one very, very quick experience, and then we're going to pause because our time is up. Go ahead, if you can, and stand up in your space. Now, if you can't stand up in your space, that's okay too. But the goal is to really experience what it feels like to live with this type of dementia in the middle of the journey. So we're going to put ourselves into emerald. So you're going to put on something called binoculars. So make 2 O's. And now for just a moment, walk around your space and notice how different your space feels, how different your space looks, and how safe you would feel if I came up behind you and put my hand on your shoulder to say, hey. So y'all can come back and have a seat. What was that like, going through just a few seconds of that type of visual change?
Scary.
Scary. Yeah.
I would hate to be outside with the road and sidewalks and dogs and things happening around me. I'd be scared.
Scary, especially if you then get touched.
Oh, yeah.
Somebody comes into your space, or I come into you and I say, hey, sweetheart, you ready for your shower?
Oh, yeah. Ooh.
Ooh. So our goal with our training, what we do is try to teach people, what it feels like on this side, because us and them doesn't really exist. I'm still human when I'm living with dementia and I'm experiencing these changes. And so if I'm experiencing these changes in my vision, in my language, in my sensory motor abilities, if you don't adapt, everything you do is going to be seen as a threat. And the moment we ask people to go into someone's room and take care of them when they're already appearing as a threat, how's that going to go for both parties? People living with dementia are aggressive. They're not. We cause that. People living with dementia are agitated and they won't do anything you say. They won't if you don't get permission. And we have those skills, and you'll learn some of those skills if you choose to join us in that. So very briefly, go ahead and put your hand up by your face and say, hey. And now check where you wear your name tag, because a lot of us wear our name tags in a place that's not. Oh, good. I like it, Dory. Good. I like it when somebody's computer recognizes their hand. Check where you wear your name tag, because right now I don't have my name tag on, so it would be hard for me to tell somebody my name. But ideally, we have our name here on our right shoulder, our hand up by our face, so that even with binocular vision, which your computer screen gives you so you can kind of see what you would look like, I can go, hey, I'm Amanda, and you are. So practice that motion of getting a permission to touch someone else. Because often what we do is we say, hey, it's good to see you. And then I put my hand out, what's the problem? With a binocular field of vision, you can't see it. And I'll think you're being resistive, when in reality, you just didn't see my offer.
Wow.
So thank you for having us. I know I ran out of time, and I apologize for that. There's so much more. There's so much more that we can offer. And all of those slides, I'll make sure to send an updated copy to Polly so that the new slides with the medication numbers will be there for y'all. Any final questions before we go? You can throw into the chat, or you can share with Stephanie after, so that we make sure we do this again. I don't want it to be a one-time thing.
Oh, I enjoyed it thoroughly. I mean, it was great. I've been to 3 of your mother's seminars here in South Carolina, and I enjoyed every one of them. Every one of them.
Awesome. Thanks so much, Veronica. And thank each of you for everything that you put into every day. You would not be here if you didn't care. and if you didn't want to change how this works, and it is exhausting.
Amanda, we are so grateful that you made time for us. I now personally know how busy you are. And the fact that you made time for us to teach us this is just so kind and generous of you. And I probably can speak for all of us that we're in awe of your mission, your knowledge, and your mom's mission and knowledge, and keep up the good work.
Thank you so much. And thanks for having me. I'll hop off now and I'll see you guys later. And I got your question, Christine, so thank you.
Thank you so much.
Thank you. Bye, everybody.
Bye.
Ah,